Son and for the Heritage Foundation for sponsoring this lunch, and to my colleagues. I put this simply, the need's pretty clear to me. We have the most expensive healthcare that money can buy, and the quality of our healthcare is pretty poor. The solution, I think, has already been put on the table. It's the stimulus monies. It's a chance to put a whole lot of money to work to incentivize people to improve the care. The problem is as Dr. Lynn's study showed, and those of us that are out in hospitals every day around the country, what we have today in the way of electronic medical records, and by the way, less than 10% of hospitals have them, doesn't have much to do with patient care. It has to do with the transactional side, as Herb described properly. So we got to make sure we don't let that money go in the wrong direction. So to me, the cure for this problem is not the legislation. We got that. Cure is vigilance to make sure that that money gets invested in a way that's going to get a return on what Congress asked for and mandated, and that is improving patient care. There is out on the table outside, there's a thick set of slides that I put together that you'll be having, I'm not going to go over, but it includes a lot of documentation on the fact that our system really is pretty poor. The Institute of Medicine told us in 1999 that we were killing about 100,000 people a year in hospitals. And since then, that number's gone up. The amount of people who get injured in hospitals is around 1 million a year, and nobody's doing anything about it. We got a 747 goes off down off the coast of Brazil, and massive forces go in place to figure out what went wrong and make sure it doesn't happen. But if you do the math, the 100,000 is equivalent of 285 747s fully loaded going down in a year. How long do you think people in this country will let that happen? Maybe the second one, maybe the third one, but I doubt it would make it past there. And yet we're still doing it, and everybody's just kind of oblivious to that. I don't get it. I think that the problem is that you get the performance that you incentivize. There's some great reports out there that point out the fact that, well, one of the reasons that we aren't getting a focus on quality is because doctors are incented to number of patients, number of procedures, etc. So what we have to do is we have to incentivize the performance that we want to get. And I think the stimulus bill is headed in that right direction. You can argue whether you think it was a good idea to put $30+ billion out for that purpose, but the fact matter is it's out there. To me, let's get the return on that investment and let's make the change. What we have to do, though, is we're going to have to make that change happen. Herb's exactly right. This is hard for docs, especially older docs that they don't necessarily even know and understand how to use all this fancy stuff. But it's hard to implement these. It's hard to get docs and nurses to use them. But if we had some stuff that helped them practice medicine, they would. We're in hundreds of hospitals around the country. We're helping deal with this. Most of the software that's out there isn't aimed at helping a doc do his or her job. It's helped at getting the documentation in place so they can recover the monies they get for themselves or their hospital. We got to change that. We got to make it help them practice their medicine. But to me, it's sitting there with that money in your hand and saying, so look, here's the way it's going to work. If you don't improve the quality, you don't get the money. Stimulus ought to stimulate improved quality. I'll give you a little story I'll have to tell because I had the privilege of serving on the board of managers of Parkland Hospital in Dallas for almost 5 years, our storied public hospital. And so we were in the middle of, when I got on the board, $60 million of investment in a healthcare IT system called electronic medical record. And yet you go out in the halls and you talk to the doctors, and they were all just really upset about all this money being wasted on something that didn't help them take care of all the patients we have coming through those doors. So we called in the head of the IT group, who's just a wonderful guy, and said, Jack, this isn't going to get it. We got to do something that's going to help docs and nurses. And he said, well, it's hard to run the railroad, it's going to take a long time, that 3, 5, 10-year kind of thing. So we said, so here's the way it's going to work. You don't get your budget approved for this year, for the rest of your EMR, unless you speed up the process of helping the docs and nurses with technology. And guess what happened? Parkland announced last week that it is now a full electronic medical record that has in the functionality that the doctors and nurses wanted, but nobody was listening to. It can be done. So to me, what's going on right now in Washington is really important. The key words in that bill, if you're familiar with it, are meaningful use and certified EHR technology. Those are the key words. Congress delegated that to HHS to come up with definitions. The Office of National Coordinator came out last week on the 16th with their definition. And by the way, it's pretty good. it's you know, if you do that little where's the needle, it's closer to patient care and patient quality than I frankly would have expected, because industry's trying really hard to say, so why don't you give us the $30 billion to put more of what we got into hospitals today, and that'll be a really good foundation to build on. And that's going to help patient quality, because as Herb said, that's just more of the same of what we got, and that's not where it's focused. So that definition, and the comments, by the way, are due today, so that's a rather short period of time to comment, but we and others are putting in comments, and I'll give you some of what I think, and they're written in here. First of all, if you read through every one of the things that are in their very detailed summary, there's nothing in there that says, if you check a box, you say, we do CPOE so we get money for that, right? Doesn't have anything that says CPOE that improves patient quality. So why don't we put that in there as part of the requirement? Because I promise you, we know how to implement these things. We can implement a CPOE that doesn't really have anything to do with patient quality. It's just getting an application up and running so we can get money. I think that's kind of an obvious missing piece. I also agree with the comments both Tevye and Herb mentioned. It's a long ways away, 2011 to 15. There are hospitals out there every day, and I list a bunch of them in my materials that I know are busy working on patient quality right now. There's a system in Florida, an Adventist system, that has been doing a lot of really great work on picking specific disease traits and dealing with them. And they're making great progress on community-acquired pneumonia. They've had some tremendous, and they're using a software application. They invented one themselves. So I agree with your comment about let's make it homegrown if that's the way it works. If they're going to do that and they can save a lot of lives and reduce a lot of costs and save a lot of pain and suffering for patients, let's incentivize them to do it. And let's give out some incentives for people that can move faster than the bill says or the regulations are going to say to move. I think that's a good thing. I also agree with the comment about let's not get too locked in on making sure that this is a good thing for all the big software vendors, because one of the things that's happened in this industry from the beginning of time is the garage kind of person. There are lots of those folks out there that are doing a really good job. Most of those garages, by the way, are in physician offices or in practices, clinical practices in hospitals. And I say if they can improve patient quality and they can save lives and they can reduce costs, I'm going to give them money to do that. And it doesn't have to go necessarily to buy this big software application. Also, I think we need to worry about regional delivery of care. Right now, if you read all of the proposals, it kind of sounds like you're saying, well, let's go help this hospital install its electronic medical record, and then they have that magic little word in there, interoperability. Let's do things on a regional basis. If somebody can come together and say, we're going to take all the hospitals in a region, all the physician practice groups, the pharmacies, the payers, get all that information online, that's going to dramatically improve the quality of care in that region. There's lots of studies that show that. So let's encourage that. There's nothing in there that says specifically to do that. I think also, I'm sure you all know, we spend about 75% of our Medicare monies on chronic diseases. So, and by the way, that has a lot to do with patient quality of care and life as well. So why don't we target some of this stimulus monies to improve the way in which we handle chronic diseases? There are technologies out there that could either be invented to do that or could just help track them, and we could end up by improving dramatically the care, the quality, and the cost. I say let's put some special incentives in place to do that. I also say let's improve the quality as fast as we can, so let's count partial performance. Meaning, if you can go out there like the hospital in Florida, the Adventist system, and you can dramatically change community-acquired pneumonia statistics and care quality, that's a good thing. You didn't say the whole world, I got that, but right now this big bang approach that some of the industry advocates are saying is, we're going to do it all at once, it'll take us 10 years. Well, what about that 285 747s that keep going down every year? I think we ought to be worrying about that. If we can whittle away at that, I think we ought to do it. So I think ultimately, my final comment is creativity. There's a lot of creativity out there. There are people that really want to go about doing this, but they're going to get rolled over if somebody, and I think it's really incumbent upon the people in Congress who passed the bill and said what they want, if somebody stands up and says, we really mean it, like we said to the Department Board, you don't get the money if you don't improve patient quality and patient care. And we don't hear about it manana, we want to hear about it now, and so do that. I think that's going to happen, but I think everybody's got to keep a really close eye on what happens on the definitions of meaningful use and on certified EHR technologies, because we're going to get the $30 billion spent. I have no doubt about that. I'd like to 5 years from now say we got a nice return on that investment, and we finally have the best healthcare money come out. As the final comment I quoted in here, a hospital CEO in Maine that I know, she and her hospital decided they're going to stomp out mistakes. And she said the test they use is, what kind of care would you want for your mother when you take her to the hospital? I think that's it.